Hello, everyone, and welcome to our module on intracranial aneurysms. So the term aneurysm in general means a weakness of the vessel wall that leads to an abnormal dilation. You'll get this drawing on the screen. This depicts a normal blood vessel. Over here is one that has an aneurysm. Wall has become weak, and so the blood pressure is pushing it outward, causing it to become dilated. And the problem with aneurysms anywhere in the body, but especially intracranial aneurysms, is that they are prone to rupture and bleeding. So in this video, we're going to talk about two different types of intracranial aneurysms. The first type are called saccular or berry aneurysms. This is the more common type of intracranial aneurysm. These aneurysms develop in large blood vessels of the circle of Willis. These blood vessels supply the cerebral cortex, so these aneurysms are also sometimes called cerebral aneurysms. And the underlying pathologic issue here is that there's thinning or absence of the tunica media layer of the vessel wall. I talk about layers of vessel walls in other videos. There's an intima, media, and adventitia layer, and the media layer becomes thin or sometimes absent in regions where these saccular or berry aneurysms develop. Second type of intracranial aneurysm we'll talk about in this video are Charcot-Bouchard aneurysms. These generally only occur in patients with severe chronic hypertension that is poorly controlled. These are much smaller aneurysms compared to saccular or berry aneurysms. They're called microaneurysms because they involve very small penetrating blood vessels. And the problem with these type of aneurysms is that they can rupture and cause hemorrhage, and this will lead to a hemorrhagic stroke. And in other videos, I talk about lacunar strokes, but lacunar strokes are caused by ischemia of these small penetrating arteries. Charcot-Bouchard aneurysms can rupture and lead to very similar clinical presentations compared to lacunar strokes. The difference is in a lacunar stroke, you have ischemia of one of these small penetrating arteries. In a Charcot-Bouchard aneurysm, you have rupture and hemorrhage of one of these small penetrating arteries. Let's talk about the clinical features in general that you can see from intracranial aneurysms. So first of all, aneurysms, if they're very large, can compress nearby structures. This only happens with berry or saccular aneurysms when they get very, very big. And this can compress neurologic structures and give you a number of different neurologic findings depending upon the location of the aneurysm. And I'll talk more about this in just a minute. The other thing that can happen with a berry aneurysm is it can rupture. And when it ruptures, it leads to a subarachnoid hemorrhage. This refers to bleeding into the space in the brain where you find cerebrospinal fluid. The main feature clinically here that occurs is headache from irritation of the meninges by blood. You can have focal neurosymptoms, but that's rare. And the reason focal neurosymptoms are rare is because blood flow to the brain tissue is maintained. The problem is that the bleeding into the subarachnoid space leads to irritation of meninges, and so the dominant feature is a headache. And then finally, as I already mentioned, when you have rupture of one of those Charcot-Bouchard microaneurysms, this can lead to hemorrhagic stroke, and this will lead to clinical symptoms based on the location of the bleeding. We'll talk more about this later. Okay, so we're going to start by talking about berry aneurysms, which, as I already mentioned, are aneurysms involving large blood vessels that supply the cerebral cortex. And one of the first things to know about these aneurysms is that they're associated with a number of underlying conditions. The three big ones you always want to remember for your boards exams are the ones written right here. The first one is autosomal dominant polycystic kidney disease. The second one is Ehlers-Danlos syndrome. And the third one is coarctation of the aorta. Any patient who has one of these three conditions or a family history of one of these conditions, right away that should bring to mind the possibility of a berry aneurysm because these aneurysms are much more common in these groups. And then beyond this, these aneurysms are more common in patients who have older age, who have hypertension, who have smoking. These are sort of general vascular breakdown type of risk factors. Next, let's talk about subarachnoid hemorrhage, which, as I mentioned, is a clinical syndrome that is almost always caused by rupture of one of those large berry aneurysms of the circle of Willis. Rarely it can occur because of bleeding from something other than a ruptured berry aneurysm. For example, some patients are born with congenital vascular malformations in the brain called arteriovenous malformations or AVMs, and one of these can rupture, causing subarachnoid hemorrhage. And there are other causes, but the major cause is rupture of a berry aneurysm. When a berry aneurysm ruptures, it will lead to blood accumulating between the arachnoid and pia mater in the meninges. This is the region of the meninges that contains cerebrospinal fluid. So to understand this, let's look at this cartoon showing the meninges. So this is the skull right here. This is the bone. And beneath the bone, the first layer of the meninges that you find is the dura mater. Below the dura mater, you find this blue layer called the arachnoid mater. And then below the arachnoid mater, you find this purple layer called the pia mater. Between the arachnoid and pia mater, where you find these large blood vessels of the circle of Willis. So if one of them develops an aneurysm and it ruptures, you will get blood between the arachnoid and pia mater. Importantly, that blood will also mix with the cerebral spinal fluid, and so you can detect blood in the cerebral spinal fluid in patients who have a subarachnoid hemorrhage. So when there's bleeding into the subarachnoid space, this will irritate the meninges, and that can lead to headache, which is the dominant feature of subarachnoid hemorrhage. And we'll talk more about this in a second. As I mentioned to you earlier, rarely do focal neurosymptoms like weakness and sensory loss develop. And the reason is that when there's bleeding in subarachnoid hemorrhage, the subarachnoid space contains the bleeding, and that allows blood to keep being delivered to brain tissue. So you usually have normal blood flow to brain tissue and you don't get focal neurosymptoms. The main problem is that blood in the subarachnoid space irritates the meninges, causing headache. Now, as we'll talk about shortly, there are treatments for subarachnoid hemorrhage, and after a patient is treated, that blood can days later trigger vasospasm of cerebral blood vessels. When this happens, that can compromise blood flow and that can lead to focal neurosymptoms. But this occurs days later, not immediately after the onset of a subarachnoid hemorrhage. So the headache associated with subarachnoid hemorrhage is very severe. Classically, patients will say it's the worst headache of their life. Also, they will often report that it came on very suddenly. It's classically described as a thunderclap headache. That's because when that aneurysm ruptures, blood floods into the subarachnoid space and immediately triggers a severe headache. There can also be inflammation in the meninges, and that can potentially cause a fever. And then patients have so much pain from these subarachnoid hemorrhages that they're often hypertensive when they present. And then the irritation of the meningeal layers in subarachnoid hemorrhage can cause symptoms of meningismus. This refers to things that you see in meningitis, things like nuchal rigidity, which means neck stiffness on passive flexion. You can also see Brzezinski's sign and Koenig's sign. These are signs classically associated with meningitis, but they also occur in subarachnoid hemorrhage. Brzezinski's sign is when you passively flex the patient's neck and they move their hips and knees in response because that causes the pain to go down. Koenig's sign refers to resistance to extending the knee when the hip is flexed. And I talk about both of these things in more detail in the video on meningitis. And then finally, photophobia can also occur as a sign of meningeal irritation. Now, fever and meningismus are symptoms of meningitis. So one thing you may be wondering is, how do you tell a subarachnoid hemorrhage apart from someone who has meningitis? And the key is the onset of symptoms. In subarachnoid hemorrhage, the symptoms come on very rapidly, almost instantaneously. In contrast, a person who has meningitis will report that they haven't felt well for hours or days with symptoms of infection, and then eventually they developed the fever and meningismus. And then once again, always remember this, in patients with subarachnoid hemorrhage, focal neurologic deficits are rare. If the patient's unable to move their arm or their leg, you should think of something else to be sure that this really is just a subarachnoid hemorrhage, because you usually don't see focal deficits in that situation. The diagnosis of subarachnoid hemorrhage is almost always made by CT scan. This test is very sensitive and it's usually diagnostic. It's most sensitive in the first 6 hours, and so sometimes if patients present and the headache has been going on for a day, CT scan can miss this, but if they present within the first few hours after the onset of the headache, the CT scan usually will be diagnostic. What you will see is blood in the basal cisterns and fissures. So to understand that, let's look at the CT scan on the slide here. Blood appears bright. And if you look closely, you can see all this bright material here filling these spaces between the lobes of the brain. These spaces are called cisterns and fissures. They contain CSF, so they're always filled with cerebrospinal fluid. And in the case of subarachnoid hemorrhage, there's blood mixing with the CSF, so you get all these bright lines here shown on CT scan. Fairly easy to recognize even at the early med student level. Make sure you know what a classic subarachnoid hemorrhage by CT scan looks like. You can also make a diagnosis of subarachnoid hemorrhage by lumbar puncture, although we don't always have to do this. This is usually done when there's a high suspicion for one of these hemorrhages, but the CT scan is negative. And what you will see on lumbar puncture is called xanthochromia. This refers to a yellow color to the cerebrospinal fluid, and it's caused by the presence of bilirubin, which comes from the breakdown of hemoglobin, which is in the CSF because there's bleeding. You can also sometimes see blood cells directly in the CSF. So in cases where the patient presents beyond 6 hours and the CT scan is negative, but you have a high suspicion for subarachnoid hemorrhage, lumbar puncture is often done. The treatment of subarachnoid hemorrhage is usually with neurosurgical procedures. One of them is called vessel clipping, to basically clip the bleeding aneurysm. Another is called endovascular coiling. That involves putting a coil into the aneurysm like what's here and causing clot to form so that it doesn't bleed any longer. After these procedures, patients always go to the neuro ICU, and one of the reasons for this is because rebleeding is common, and so often these patients need routine CT scans to make sure there isn't any additional bleeding. The major complication, which I mentioned earlier, is vasospasm of cerebral blood vessels. This is often triggered by blood, and it occurs 3 to 12 days after the initial bleed. So what will happen is the patient will be recovering well in the neuro ICU, but 3 or 4 or 5 days after their bleed, they will develop weakness of their arm or leg or sensory symptoms. These are focal neurosymptoms, and they're caused by spasm of blood vessels that deliver blood to the brain. And then you should also know that cerebrospinal fluid is always being produced and reabsorbed inside of our brain. And so the blood can clot and block the reabsorption of cerebrospinal fluid. If this happens, this will lead to a condition called communicating hydrocephalus. I talk about this in other videos, but it involves increased intracranial pressure and dilation of the cerebral ventricles, and this can occur as a consequence of a subarachnoid hemorrhage. In order to treat or prevent the development of vasospasm, almost all patients with subarachnoid hemorrhage receive intravenous treatment with the calcium channel blocking drug nimodipine. This is a calcium channel blocker that's lipophilic, so it crosses the blood-brain barrier, and it's been shown in many clinical trials to improve outcomes in subarachnoid hemorrhage. It's believed to prevent vasospasm. That's believed to be one of its mechanisms of action, although there have actually been some elegant studies that have shown that the drug improves outcomes even in patients who don't have vasospasm. So we don't completely understand how it works, but the bottom line is that this calcium channel blocker is almost always given to patients with subarachnoid hemorrhage to improve outcomes generally and also to prevent vasospasm. In most patients, you start this drug at 48 hours after the onset of their bleed, or sometimes sooner if the patient has become stabilized. Okay, so now let's talk about the anatomy of Berry aneurysms, and by this I mean where in the cerebral blood vessels do these aneurysms occur. So the first thing to know is that most of these aneurysms are asymptomatic until they're ruptured. And in the modern era, we do so much imaging of the head that we often incidentally find one of these aneurysms in someone who has no symptoms whatsoever. Now, as we've already discussed, when they rupture, this can cause a subarachnoid hemorrhage, but unruptured aneurysms can sometimes also cause clinical features due to so-called mass effects. In other words, the aneurysm gets large enough, it can compress nearby structures, leading to symptoms, even though it hasn't ruptured yet. These symptoms can include things like headaches or seizures. They can include visual loss. You can see cranial nerve defects. And the specific clinical features that you see vary with the site of aneurysm, and that's what we're going to talk about in the next few slides. Certain anatomic locations tend to lead to certain clinical features if the aneurysm is large and unruptured. So shown on this slide are the most common locations for Berry aneurysms. The most common location overall is the middle cerebral artery. This is responsible for about 30% of these aneurysms. You should know, however, that the most common location for a ruptured aneurysm is actually not the MCA, it's the anterior communicating artery. And so in some of these lists of most common locations for Berry aneurysms, you'll see anterior communicating artery at the top of the list, and that's because it's a list of the most common sites of rupture. What I'm showing you here are the most common sites overall. Other places where you can see these aneurysms are in the internal carotid artery, the basilar artery, the ACA. PCOM aneurysms are relatively uncommon, but they can cause visual field defects, and we'll talk about this in a second. And then you can also see aneurysms involving the vertebral artery and the PCA. So middle cerebral artery Berry aneurysms are the most common location for Berry aneurysms overall. And you should know that it's rare, but these aneurysms can sometimes cause ischemia in the MCA territory. So first of all, if the aneurysm is enormous, it can compress the MCA artery. So let's look at this drawing right here. This is a middle cerebral artery aneurysm, and you can imagine if this aneurysm gets enormous, it can actually compress the MCA, leading to ischemia. You can also sometimes, it's rare, but you can sometimes see rupture of one of these aneurysms where so much blood is lost that you decrease blood flow generally to the MCA territory. And when this happens, this will lead to typical symptoms of MCA ischemia, which I talk about in videos on strokes involving the MCA. So these are symptoms like contralateral weakness that's greater in the upper extremities than the legs, and also facial hemiparesis. Berry aneurysms of the anterior communicating artery, as I mentioned earlier, are the most common location for a ruptured aneurysm. Usually these aneurysms develop at the junction between the anterior communicating artery and the anterior cerebral artery, so this junction right here. And you should know that running right here above this region shown in my drawing is the optic chiasm. So if you get a very large unruptured anterior communicating artery aneurysm, that can compress the optic chiasm, and this will lead to visual field defects. The specific type of defect you get from compression of the optic chiasm is called bitemporal hemianopsia, and I discussed this in detail in videos in the ophthalmology section. You should also know that if you get rupture of an anterior communicating artery aneurysm, days later when vasospasm occurs, this commonly involves the ACA territory. So vasospasm and ischemia in the ACA territory gives clinical features similar to an ACA stroke, which I talk about in other videos. This causes contralateral weakness, and the legs tend to be affected more than the arms. The posterior communicating artery is a relatively rare site for Berry aneurysms, but you should know that a very large aneurysm at this site right here can compress cranial nerve 3, and that can lead to a cranial nerve 3 palsy. Large aneurysm of the posterior communicating artery is a classic cause of a CN3 palsy. And a CN3 palsy, which I talk about in detail in other videos, presents with an eye that is tilted downward and outward. That's what's shown here. This eye is down and out. There's also ptosis, meaning drooping of the eyelid. And you can also get a pupil that is dilated. You can see this pupil is dilated relative to the normal side. Not only will the pupil be dilated, but it will be non-reactive to light. It's basically fixed in the dilated position. So that brings me to an important point about cranial nerve 3 palsies, and that important point is pupil sparing. So anytime a patient has a cranial nerve 3 palsy, meaning that the eye is located down and out and there's ptosis of the eyelid, what you want to ask yourself is the pupil normal, meaning is it dilated or not? If the pupil is normal, meaning it's not dilated, then we say the pupil is spared, and this means that the cause of the cranial nerve 3 palsy is not a Berry aneurysm. The reason for this is that the pupillary constrictor nerves are easily compressed in the subarachnoid space by an aneurysm. So if an aneurysm is causing the cranial nerve 3 palsy, you should have a dilated pupil. But if you don't have a dilated pupil and the pupil is spared, this means the palsy is not due to an aneurysm. These types of palsies where the pupil is spared are usually associated with diabetes. They're caused by ischemic neuropathy of cranial nerve 3 involving small vessels. Sometimes these are painful neuropathies, so the patient can report eye pain. These often spontaneously resolve. And so this is summarized in this picture right here. If we have a patient who has a cranial nerve 3 palsy and the pupil is dilated, then what's probably happening is they have a Berry aneurysm of the PCOM vessel. It's compressing all the nerve fibers involved in cranial nerve 3, including the pupillary constrictors. On the other hand, if the pupil is spared and it's not dilated, then you probably do not have an aneurysm of any of the vessels in the central nervous system. Instead, what you have is vascular disease causing microvascular ischemia, and this is called the rule of the pupil. Okay, now let's switch gears and talk about Charcot-Bouchard aneurysms, which, as I mentioned earlier in this video, are microaneurysms of small arterioles that supply blood to deep regions of the brain. They're called microaneurysms because they're too small to visualize on angiography. These are really something that's identified on pathologic examination of the brain. And really, the thing to know about these is that they can rupture, and this can lead to intraparenchymal hemorrhage, otherwise known as a hemorrhagic stroke. The underlying cause of most hemorrhagic strokes is rupture of these types of microaneurysms. You should also know that they're strongly associated with hypertension. They mostly occur in patients who have high blood pressure, especially if that high blood pressure is not being treated. On a pathologic level, the underlying cause is lipohyalinosis. This is a certain kind of degeneration of the vessel wall. The arterial vessel wall fills with lipid-rich macrophages and also fibrinoid material, and it gets weak and it's prone to rupture. If you want to just remember one place where these microaneurysms occur, remember the lenticulostriate arteries. These are branches of the middle cerebral artery. So if you look at this diagram right here, I'm drawing a line with my pen through the middle cerebral artery, and it gives off these small penetrating branches. Those are called the lenticulostriate arteries. And so these microaneurysms commonly develop in these blood vessels, and so when they rupture, they give you bleeding in deep portions of the brain, not out here in the cortex. The bleeding is usually deeper down here near the basal ganglia and the internal capsule. So as I said before, when these aneurysms rupture, that leads to a hemorrhagic stroke. And usually the stroke involves so-called deep regions of the brain. This means not the outer cortical regions like these regions out here, but deep structures down in here. Usually it involves the basal ganglia and the internal capsule. Now the internal capsule contains sensory and motor fibers that supply the entire body. So when you have one of these aneurysms rupture and you get bleeding into the internal capsule, the clinical feature that usually occurs is contralateral hemiparesis and sensory loss. This is all from damage to the internal capsule. It's often described as dense paralysis and sensory loss, meaning the arms and legs and also the face are affected equally, unlike in MCA or ACA strokes where you get the legs or the arms affected unequally with one more than the other. And then when you do a CT scan, you can diagnose the fact that the patient has had a rupture of one of these aneurysms by identifying bleeding in deep structures. Blood is fairly easy to identify on CT scan. This is a deep bleed in the brain in this CT scan at the bottom of the slide here. This is another one here in the upper CT scan. And I talk in more detail about hemorrhagic stroke in other videos on stroke. In this video, I'm just touching on these aneurysms so that we can cover all the different types of intracranial aneurysms. And that concludes our module on intracranial aneurysms.